Let's record. Okay, so I wanted to pull this slide up again just to show you an important concept here. And that is this. I'll circle it. I need to stay in my seat. The microphone can hear me better. This right here, we're going to revisit this in a moment. All right, but when we talk about blood pressure, it is dependent on those three variables. Cardiac output, okay, our resistance, and then blood volume. How much blood is circulating throughout your circulatory system. I can guarantee you that you are going to see at least one question, possibly more, that are going to discuss, all right, blood pressure and blood flow. So you want to understand that cardiac output, resistance, and blood volume play a role in that. Okay? So most likely, if you increase any one of these three, all right, you are going to increase blood pressure. Okay? So just a reminder, all right, cardiac output, everybody should know this equation by now, is equal to the heart rate times the stroke volume. All right? Again, this equation you don't have to know, but I like it because it just helps me understand the concepts a little bit more. Blood pressure is equal to heart rate, all right, times, all right, the total peripheral resistance, the afterload. All right, what's going on in the blood vessels? All right, we know how to increase resistance. Quick review, there's three things that increase resistance. One is we make the blood thicker, the blood viscosity. Let's make it, instead of being motor oil, let's make it into syrup. All right, that's definitely going to increase our total peripheral resistance. All right, another thing is to make the actual length of the blood vessels longer. All right, so if we make the blood vessels longer, that's going to increase total peripheral resistance. And we saw that with angiogenesis. Okay? And then the third factor with total peripheral resistance is going to be the blood vessel diameter, or the radius. Okay? If we make the radius bigger, or the diameter bigger, that's going to decrease the resistance. If we make it smaller, vasoconstriction, then we increase the resistance. Just a couple things that you want to kind of keep in mind. So if we do any of those three for the total peripheral resistance, all right, blood, we'll call it blood viscosity, or if we actually, all right, increase, well, if we, let's say, increase the blood vessel length, or BV length, that'll increase total peripheral resistance. Or if we decrease the lumen, make the diameter smaller, vasoconstriction, that'll also increase total peripheral resistance. Okay? But this is what we're going to really kind of hit on today. We're going to talk about blood pressure. All right, so cardiac output, resistance, and blood volume. You increase any one of those, you're going to increase blood pressure. Easy to remember. Okay? Well, we already see it here. Heart rate and cardiac output, and heart rate and blood pressure, that's a common variable. So if you increase heart rate in either one of those, you're going to increase either one. Okay, I'll increase my cardiac output if I increase my heart rate. I'll increase my blood pressure if I increase my heart rate. Okay? All right. So last week we talked about how you have, for regulation for blood pressure, both neuronal, all right, the nervous system and the endocrine system are going to regulate your blood pressure. All right, we talked about how when we stimulate the cardio-acceleratory center, or if we stimulate the cardio-inhibitory center, how that affects your blood pressure, and what happens with the vasomotor center if we vasoconstrict versus vasodilate. We learned all about that. All right, so that was when we were talking about baroreceptors. Okay. So now we're going to talk about the other type of receptor, the chemoreceptor. All right, so the chemoreceptor, if you look at it, we learned about these in chapter 16 in 210. Chemoreceptors monitor the chemical content of your blood. Okay, so you have these special receptors that are scattered throughout. All right, the two main areas are going to be the aortic bodies, which are in the arch of the aorta, and then the carotid bodies, which are in the carotid sinus, or that area where the common carotid artery splits off into the internal and external carotid. Okay? So that's the bifurcation of the carotid sinus there. All right? So here's what happened. And we're going to base all of this on, you know it, negative feedback. To review, a negative feedback is, all right, the action taken is going to be in the opposite direction of whatever the stimulus was. So if your blood pressure decreases, all right, the reflex is going to increase the blood pressure. That's the whole concept of the negative feedback, okay? So in this case, we want to return our blood chemistry to normal. So we're going to talk about what is going to affect our blood chemistry. Believe it or not, carbon dioxide plays a huge role, a huge role. If you have a lot of carbon dioxide floating around, right, that means you're not going to have enough oxygen. So carbon dioxide is our waste, oxygen is going to be our nutrient, okay? So these things here, high carbon dioxide, all right, low pH, what does that mean? pH, low pH. That means that your blood is acidic. Low pH, acidic, high pH, basic or alkaline. All right, our normal range or the set point for that is 7.35. Okay, excuse me, take that back, is 7.4. The range is 7.35 to 7.45. That's the range, but we fluctuate. We want to keep it at 7.4, which is close to neutral. It's a little bit on the basic side.
For what?
For blood pH, okay? So, and then the other factor is very low oxygen. Well, that's a problem. So anyways, if you have these going on, high carbon dioxide, low pH, or your blood is acidic, or you have low levels of oxygen, this is going to stimulate those chemoreceptors. That's going to be our stimulus. And those chemoreceptors now are going to initiate a negative feedback scenario or reflex to try to increase low oxygen levels or low pH values or decrease carbon dioxide levels. All right, that's what we're going to see. How do we do that? We're going to increase our blood pressure. By doing so, when we increase our blood pressure, we are now shifting the blood, all right, to the lungs. Perfect. Because then we can blow off the carbon dioxide. All right, so we're knocking out all of these issues here. And we'll talk more about, I'm not going to focus on the pH because that's going to be later on when we get to acid-base balance in the body. So that's another chapter. All right, but for right now, we're going to shift that blood to the lungs. We're going to blow off the carbon dioxide, thereby decreasing our carbon dioxide levels, and we're going to increase our oxygen levels. So we've taken care of low oxygen, and we've taken care of high carbon dioxide. Again, we'll talk about what actually happens, all right, how we correct the low pH. We're going to talk about respiratory and metabolic acidosis and alkalosis later on, okay? So just keep in mind, all right, this whole process is going to undergo our negative feedback reflex, okay? So we're going to stimulate the respiratory system to increase your breathing rate, breathe off that carbon dioxide, get that oxygen in there, and we're going to increase our blood pressure. All right, so we're going to stimulate the cardiovascular system. Okay, we can do that a couple different ways, and we'll talk about that here. All right, so mind you, when we're dealing with the chemoreceptors, all right, when we're talking about the chemoreceptors in the aortic arch, we're dealing with vagus, cranial nerve 10. You need to know that. In the carotid bodies, all right, in the carotid sinus, we're dealing with glossopharyngeal nerve. That's cranial nerve 9. Okay? So 9 for the carotid sinuses or the carotid bodies. The aortic bodies are going to be cranial nerve 10, vagus. All right, so this is how we monitor. Those receptors there are constantly monitoring the chemical content of your blood. And if it notices that your carbon dioxide levels are increasing, okay, we're going to undergo, all right, we're going to shunt the blood into the lungs. So we're going to do a little bit of total peripheral resistance. We're going to do some vasoconstriction. Move blood out of the venous supply, get it into the pulmonary circulation, get it to the lungs so you can breathe off that carbon dioxide, so you can increase that oxygen level. Then we can circulate it out through the blood, right? So just remember, this is a be continued for pH. I know I've got you wanting it now, but you're going to have to wait. Okay, So when we get up into the central nervous system, especially into the higher brain centers, of course we have to involve the hypothalamus. All right? And our hypothalamus, all right, is going to initiate some of these changes on its own by increasing our cardiac output and resistance. Well, that's great because guess what? The hypothalamus plays a huge role in monitoring fight or flight. All right? What's fight or flight? Sympathetic nervous stimulation. Boom. There you go. Hypothalamus, well, it stimulates the sympathetic nervous system, and you know what that does. The sympathetic nervous system will stimulate the cardioacceleratory center, increase your heart rate. Well, the sympathetic nervous system is the only division of the autonomic nervous system that has any type of influence over your vascular tissues. All right? The parasympathetic has nothing to do with your peripheral vascular system in regards to vasoconstriction and vasodilation. Okay? So the hypothalamus takes care of that for you. And it can also increase body temperature. Well, what does that do? Right? Back to chapter 1. All right, with homeostasis. When you increase body temperature, because your blood is about 1 degree warmer than your normal body temperature, right, you will get blood shunted out to the skin to give off that heat. Okay? That in itself will help to increase, all right, your flow, but also your blood pressure. So we've increased the blood pressure. How about the limbic system? Well, you know, anytime you get emotional, all right, a lot of physiological changes can occur. Fear is a great motivator, all right, and that is generated through the limbic system. All right, the hypothalamus plays a role in that, but the limbic system can now alter blood pressure based mainly on emotions, but we know that emotions can be affected by memories. All right, if you have a bad memory, you know, you see it all the time with anxiety attacks. People that may have been in a car accident, all right, and they get into a car that looks like their car or whatever, then they start to stimulate the limbic system, and then they can start to increase their breathing rate, and then their heart rate increases too, all right, because they get that, I won't call it an anxiety attack, but it stimulates the sympathetic nervous system. They start to increase. So the limbic system can play a role also, all right, in the regulation of the blood pressure. It's going to be another neuronal tissue, all right, factor that plays a role. All right.
When your blood pressure goes up, like, is that the feeling that makes your heart rate really, really, really fast?
Part of it. And again, it has to be a significant increase, because remember, when your blood pressure goes up, all right, if your heart rate's going to increase, and usually that's a sympathetic response to something, all right, the sympathetic nervous system increases heart rate, but it also can increase the force of contractility. So it can make your heart beat harder, more forcefully. A combination of both of those things is what you're feeling. You're going to feel those palpitations because it's beating not only faster, but more forcibly. And that's what you notice that.
The other day from the bathroom, and literally, like, I felt like my heart was beating on my chest, like, my heart rate was really fast.
Sure. Was
I was really sweaty. And
was it a dream or a nightmare?
it was a dream/nightmare.
Oh,
I had
right.
a dream my daughter, like, fell into this, like, you know, the little big holes that drain water into them?
Oh, the culverts, yeah. Oh, yeah.
I had a dream that, like, she slipped into one, and I couldn't catch her, and, like my whole body was shut down. I had to tell myself, like, wake up, like.
Oh, wow.
I woke up freaking out. Like, my husband was like,
Yeah.
I mean, I couldn't breathe.
But but those are physiological responses to that. You know, I had a dream last night that my daughter's school principal was trying to kill me, and I caught him. I got him. He tried to shiv me, and I got him. I didn't kill him. But I apprehended him and I returned him to the authorities, which was really weird because he's a really good guy, and I just like, why are you trying to kill me? Very odd. Right. And I was actually really excited because I actually remembered my dream. Okay, so let's talk about the endocrine nervous system. Excuse me, the endocrine system. The other parts, all right, of how we regulate our blood pressure. Now, mind you, keep in mind, the nervous system response to blood pressure regulation is going to be fast. Okay, the onset and the results of it are quick. Okay, when we deal with the endocrine system, it takes a little bit longer because we have to generate the hormones. Then we have to get the hormones to circulate through the body. But the nice thing about the hormonal regulation is it's more sustained. Okay, nervous system is like a light switch. Turn it on, turn it off. Boom, boom, boom. Done. Okay, but when we get to the hormonal regulation, okay, it takes a little bit longer. So let's start off with the renin-angiotensin system. This is a cool system. All right, we'll talk about it a little bit later on too when we get into the kidneys, into to the urinary system too. All right, but for right now, believe it or not, all right, I haven't talked about this, but the organ that plays a really huge role in blood pressure regulation are the kidneys. Okay, are the kidneys. All right, we'll talk about it more when we get into the kidneys, but keep that in mind. So I'm going to tell you a little story. Remember when we were dealing with vitamin D? There was 3 organs that worked on making vitamin D active. The skin made vitamin D in the inactive form, then the liver converted it to something, then the kidneys converted it into the active form. Similar here. We've got 3 organs, okay? So we're getting rid of the skin, and instead of having the skin, we're going to put the lungs in place. Okay, so it all starts off with the liver. So the liver makes this inactive angiotensinogen. Okay, it's just protein, it's just floating around, and it makes it all the time. So you've ever heard the saying, it's better to have it and not need it than to need it and not have it? Well, that's the liver's philosophy in this situation. It's like, I'm just going to make this stuff because I might need it later on. And so it's already in circulation, it's in play, but it's inactive, it's not doing anything. Okay? So it floats around, and then remember, here's our buddy here, the kidneys. All right, remember what I said? They play a big role in blood pressure. All right, so they notice that there is a decrease in blood pressure. Okay, so they notice a decrease in blood pressure. So like, oh, all right, let's take care of this. So they produce renin and release it into the blood. And so the renin, all right, will interact with the inactive angiotensinogen and convert it into angiotensin 1. Okay, so this is going to either be the kidneys that are going to release the renin, all right, or our sympathetic nervous system is going to stimulate that. Okay, so now the renin is converted the angiotensinogen, which is the inactive protein, all right, into angiotensin 1, which is still inactive. It's not going to do anything yet, all right? It just needs to go somewhere. So guess where it's going to go? To the lungs. It travels to the lungs, and there is an enzyme that sits on the inside of the capillaries in the lungs. And it sits on the inside of the capillaries, and when angiotensin 1 comes in contact with this enzyme, which is called angiotensin converting enzyme, we call it ACE for short, okay? When it interacts with that enzyme, it's converted into the active form of angiotensin 2. Okay? So I'm going to show you, let me show you the picture here. I'm going to come right back to this slide. I love this picture. Figure 2015. Okay? 2015 in your book. I'm going to kind of go out of order here just a little bit. All right, so here's the liver. All right, it's continuously pumping in angiotensinogen into your bloodstream, right? And it's inactive, okay? So the kidneys are minding their own business, but they're monitoring the blood pressure, and they say, oh, blood pressure's dropping. Okay, so here's what I'm going to do. All right, I'm going to release, all right, renin because the blood pressure is low or because the sympathetic nervous system told me to. So it pumps out the renin, and that gets pumped into the blood, and it converts the angiotensinogen into angiotensin 1. Still inactive, though. Okay? So it floats around, and it winds up in the capillary system of the lungs. And on the capillaries, just lining the capillaries, we have this enzyme, the angiotensinogen converting enzyme, and it converts the inactive form of angiotensin 1 into the active form of angiotensin 2. Okay? So now we're going to talk about what angiotensin 2 does. Has anyone ever heard of ACE inhibitors? All right, it's a form of medication that helps to deal with blood pressure. People with high blood pressure, they'll give them ACE inhibitors. It inhibits this enzyme here, so now we can never make, I shouldn't say never make, all right, but we can't make the active form of angiotensinogen 2, or angiotensin 2, excuse me. Okay, so let me go back to the previous slide here. Okay, so what does all this do? Okay, Negative feedback system, low blood pressure. We want to increase it. So angiotensin 2 is going to raise the blood pressure. How? Increases resistance. All right, here we go. Not again, Dr. Kaz. Blood pressure, all right, equals heart rate, all right, times total peripheral resistance. I don't know why our department doesn't teach us, require you guys to learn that that equation. It's a very helpful equation. All right, but I guess we don't want you to fill up too much, because then your brains won't be able to put the other information in there. Okay, so it causes vasoconstriction. All right, well, what's that going to do on our equation down here? What does vasoconstriction do? But in our equation, which of these values does it affect? Which variable? Heart rate or total peripheral resistance? Yeah, TPR. Great. So it says it right here. It's going to raise the resistance. Okay, that's good. That's going to increase. So we know if it raises the resistance, it's going to raise blood pressure, right? By our equation. Simple plugging in. Okay, so what else does it do? Whoa, stimulates the thirst center. Well, what the heck does that? Who cares? That's going to increase our blood volume. Remember the three things that affect blood pressure: blood volume, right? Cardiac output, and resistance. Those three things, keep that in mind. That's what I started off today's lecture with. Those three things, all right? Peripheral resistance, all right? Blood volume and cardiac output. You increase any of those three, you're going to increase your blood pressure. Okay? So now we've increased the resistance, we've increased the blood volume. What's left? Well, let's focus on the kidneys still. Guess what, kidneys? You're going to stop making urine, or you're going to significantly decrease the amount of urine that you're making, because the kidneys are filters. They filter your blood. Okay? So if you have too much of something, they'll get rid of it for you. It's kind of nice. If you have too little of something, they'll reabsorb it. They'll keep it. Okay? So what are we going to do? We're going to decrease the urine output. So we're going to keep water in your blood. It's going to add to your blood volume. So we're going to maintain our blood volume. And then it's going to stimulate the release of aldosterone and antidiuretic hormone, which is what we're going to talk about here. So this whole renin-angiotensin axis here plays a big role in the hormonal aspect or the endocrine aspect of your blood pressure. Okay? So the fact that angiotensin 2 does all this is quite impressive. So you can see how an ACE inhibitor is going to make a big difference in your blood pressure, because it's going to definitely cut out vasoconstriction, because it's going to block that. It's going to decrease the formation of aldosterone and antidiuretic hormone. All right? It's not going to stimulate the thirst center. All right? And then the kidneys aren't going to decrease their urine function. They're going to, if anything, go to normal levels, and you'll pee more. Not more, but you'll pee normally. Okay?
And if you're dehydrated,
When you're dehydrated, because your blood volume, think about it, your blood volume, if it's not corrected initially, yes, your blood volume will decrease. So, and that's going to start to decrease your blood pressure. Go ahead. Well, yeah, hopefully you are, but no, yeah, initially, because, well, and we're going to talk about that with aldosterone and antidiuretic hormone, because that leads into that. Because if it's not corrected right away, like initially, this takes a little bit of time. All right, we got to get the hormone cells, excuse me. We got to get the glandular cells to produce the hormone, and then it's got to get shipped out to the target cells. And the target cells have to take effect. So that takes a little bit of time here. All right, so if in case you don't remember, all right, the details about aldosterone, I'll remind you. I know chapter 17 was several weeks ago. All right, but aldosterone, it's made in the adrenal cortex, all right, in the zona glomerulosa. It's a mineral corticoid, okay? So our stimuli for this is going to be angiotensin 2 production. That angiotensin 2 is then going to trigger the release of aldosterone. Okay? So aldosterone is simple. Water is such a follower. You know, if it was in middle school or high school, it would be the peer pressured substance in the body. All right, it's such a follower. It follows glucose where glucose wants to go. And guess what? It's going to follow sodium. All right, so wherever sodium goes, water is going to follow it. Okay, so that means if the kidneys pee sodium out, water is going to follow it. If the kidneys pee glucose out, water is going to follow it. So if the kidneys are going to keep sodium and reabsorb the sodium, water is going to follow it. So that's what we're going to see here. All right, we're going to see not only the kidneys going to decrease the amount of urine formation, which is going to help to bolster up, all right, our blood volume. Now they're going to increase the absorption of sodium. Okay? And so the kidneys are going to make sure that they don't get rid of sodium in the urine, what little urine they're producing. Water follows the sodium. Where does it follow it to? Back into the bloodstream. And that helps to maintain your blood volume, thereby decreasing the amount of urine you're peeing out. Cool? Well, we're not done yet, because guess what? Now we got ADH, antidiuretic hormone, also known as vasopressin. All right? So we learned about this in chapter 17. The hypothalamus is going to trigger the posterior pituitary, all right, to release, all right, our ADH. Guess what? The posterior pituitary does not synthesize ADH, right? Who makes the ADH? Huh? The hypothalamus. The hypothalamus, remember, there's two hormones that are made in the hypothalamus. They get shipped down. That's right, Lucy. The hypothalamus is going to make two things. ADH is going to be the one that gets sent down to the posterior pituitary. The hypothalamus will stimulate the posterior pituitary to release it. All right. Yeah, and oxytocin. Yep, very good. So the posterior pituitary then releases, all right, antidiuretic hormone into the bloodstream, okay? So we're going to see, all right, angiotensin II will play a role in that, but also, all right, if we see an increase in blood concentration, what does that mean? An increase in blood concentration means that the water content in your plasma is decreased. Your hematocrit, which is how thick your blood is, all right? If you have a high hematocrit, probably because you might be dehydrated, okay? So you have that dehydration going on, so you have less water in your plasma, which means you have a higher ratio of the blood-formed elements, all right? So the hypothalamus picks up on that, stimulates the posterior pituitary or the production of angiotensin II, okay? Regardless, ADH is now going to affect the kidney even more, okay? It is going to prevent urine formation from occurring, so you'll pee less. So now we have another hormone that's going to be working on the kidney. It also is going to stimulate our thirst center, okay? All right, we've seen that before. Aldosterone did the same thing, all right? Angiotensin II did the same thing. So we're going to increase our blood volume here, all right? But in large amounts, this is the big difference with ADH. This is why we call it vasopressin, excuse me. It causes vasoconstriction. Causes the peripheral blood vessels to vasoconstrict, thereby increasing our blood pressure because it increased TPR. Questions on that? You kind of see where I'm going with this? It's kind of like a story if you understand all the players involved. Okay, so that's ADH, antidiuretic hormone. And that brings me back to this part here. The variables that influence your blood pressure. Okay, homeostasis. I've heard that term before. That's that healthy balance of your body, keeping everything in that normal functioning range around a set point. Okay, so when we're talking about blood pressure, cardiac output, resistance, and blood volume are going to directly relate to blood pressure. What does that mean? If one goes up, the other goes up. It's that simple. I increase my blood volume, I'm increasing my blood pressure. If I increase the resistance, I'm increasing my blood pressure. Y'all see that relationship now? Good. Because when you take this test, you're going to rock it. You're going to know it. You're going to be like, I get it now. I understand, why this all happens. Okay? So let's talk about AMP, atrial natriuretic peptide. We talked briefly about this in chapter 17. All right? This is when we increase, all right, our blood pressure as a result of low blood pressure in the atria. Okay? So you know that the atria have baroreceptors, okay, that are located in the walls, all right, of the atria there. So when there's a decreased stretch, all right, or if there's an increased stretch, all right, that's going to affect, all right, the amount of atrial natriuretic peptide, AMP, being released. Okay? So if you have an increased blood pressure, all right, we saw what happens when your blood pressure is low. Okay, we saw what happens with the angiotensin 2 axis there. We saw with what aldosterone does. We saw what ADH does when blood pressure is low. Now, blood pressure has gotten high. Okay, so more blood is returning to your heart. Okay, and it stretches the walls of the atria. Okay, so the atria then will start to secrete the AMP, which causes vasodilation. That is going to decrease your peripheral resistance, or what's another name for peripheral resistance? Afterload. It's going to decrease afterload. Okay? So if we cause blood vessel dilation, we'll have decreased resistance. Whoops. There's an A. All right, then we'll have decreased blood pressure. All right, at the same time, it's going to tell the kidneys, hey, make more urine. Get rid of that blood volume. Let's decrease the blood volume a little bit. So get rid of some water. Okay, so that's what we're going to see, a lowering of the blood volume. All right, which is perfect because look, down here we already said, all right, if we increase any of these things, we increase blood pressure. So therefore, if we decrease any of them, we decrease blood pressure. Okay? So that's what we see here with the atrial natriuretic peptide. All right, so now, easy stuff to talk about. Okay? Except the hardest thing for me all day long is going to be to pronounce this word here. Sphygmomanometer. All right, try saying that really fast. Okay, so when you go in, aka a blood pressure cuff, when you go in to get your blood pressure measured, okay, doctor, nurse practitioner, whoever is going to place the blood pressure cuff, sphygmometer, onto your brachium, your arm. Okay. Now it's not the only place. Just in case you're wondering, that is not the only place to place it. It's just placed there because it's convenient. You can actually, I've had to do it on a person's leg before because the person I was doing blood pressure on didn't have any arms. So do it on the leg. Okay. Point being is, what you're going to do is, all right, in this case, if we're going to do it on the arm, we're going to assess the brachial artery. Okay. So the medical professional is going to inflate the cuff, all right, until we have completely cut off the blood flow to that blood vessel. Okay, momentarily. And then we start to decrease the air pressure inside the cuff. And we listen. And when you hear that first noise, that is going to be your systolic value. What's systolic value? When the heart contracts. Okay? So that top number, all right, that 120, all right, over 80, that top number is the systolic. That's the first noise that you hear. Okay? So you gradually let the air pressure out and let it go away and let it go away. All right? Where you hear it last, all right, that is going to be the diastolic pressure. That's the bottom number. That's the 80. That is when the heart relaxes. Okay? And so that's when you won't hear the blood flow any longer. Okay? So the first sound is systolic pressure. The heart's contracting. Okay? And then the last time that you hear it, all right, that's going to be the diastolic pressure, when the heart is relaxing. We can't hear the blood flowing anymore. Okay? So we no longer hear the sound. I won't say it's that simple. All right? It takes, who here has done blood pressure before? Okay. So, sure, when I first started doing it, it was like, what the heck? You know, you're trying to find out, and there's different techniques to palpate out the brachial artery, and then how you inflate it, how far you go. To be honest with you, I don't know how you do it, but I mean, there's a method where you palpate it out when you hear it, then you inflate like another 20 or 40 millimeters of mercury past when you first heard it. I usually just go up to about 200, 220. And I shouldn't be hearing it then, because if I am, that's a problem. All right. And so then I just deflate it. If I do hear it, then either something's wrong with my equipment or this person's got bad blood pressure. So, I mean, there's different ways to do it. Once you've been doing it for a while, it's as simple as driving your car. All right. But the first couple times when you're learning how to do it, you're like, dang, what am I doing? Okay. So that leads us to this, hypertension. Okay. And hypotension, when your blood pressure is too high. So hypertension is going to be elevated, chronically elevated blood pressure. All right. So our values, and I know I've written this down before, all right, for normal blood pressure right now is 140 over 90 is at the high end, and then 90 over 60 is at the low end. And on average, we're dealing with 120 over 80. Okay. So if it's above 140, you're hypertensive. Okay. And there's different grades for levels of hypertension. If you're 160 and above, it's grade 2. Oh, if it's 140 and above up to 159, you're grade 1. Then if you're 160 to 180, it's grade 2. And then above that, you're grade 3. And you're just a heart attack waiting to happen. Okay. If it's chronically elevated. All right. So remember what we said. When we're dealing with blood pressure, we want the blood pressure to be enough to perfuse the tissues. All right, we need it to be high enough to get the blood out to the tissues that need it, but not too high where it's causing blood vessel damage. So if we are seeing that the blood pressure is too high, like in hypertension, we can cause damage, and we call that atherosclerosis. Because the beginning part of atherosclerosis always involves some sort of damage to the blood vessel. Okay? Most times it's going to be because of blood pressure numbers are going to be too high. Could be a physical insult too, something can happen. Okay? But that's usually what we're talking about. The term that we refer to as to arterial sclerosis, that means we're getting a thickening of the arterial walls. All right? Doesn't necessarily mean that's a pathology, but that's the term that we give, thickening of the arterial walls. In most cases, it's because of some sort of pathology. Okay? But of course, we're always going to worry about heart failure. Okay? Chronically elevated blood pressure, all right, for whatever reason, well, there's several different, I won't go through all the, the possible causes and dangers of it. But if it's chronically elevated, the heart in most cases is going to be working more than it should. All right, it's like retirement. It shouldn't have to work hard. All right, it should be relaxing. Well, not relaxing, but you know what I mean. All right, and then finally we've got our hypotension. This is when we have chronically low blood pressure. All right, so this may have happened to some of us. In some cases, if you're sick or all right, you've cut yourself and your blood pressure drops off. All right, you'll get symptoms of fatigue, tiredness, dizziness, fainting. A lot of that is because when the blood pressure is low, that means we're not getting enough tissue perfusion. We're not getting those nutrients, things that those tissues need. And so these are the symptoms. All right, shortness of breath is another one. Okay, these are little things that we should be looking at. All right, they can be somewhat subtle in the beginning, but if it's a chronic situation, if this is happening a lot, these people need to be looked at. All right, we need to find out what's going on. All right, so the values that we're going to see are 90 over 60 is the low end of normal. So anything below 90 over 60 is going to be hypotension. Okay. And then I'm sure everybody at one time or not has experienced orthostatic hypertension. You stand up too fast. All right, when you stand up to leave your class, when a lot of you are virtually running out of here to get away from me after class, all right? If you stand up too quick, all right, or you just stand up, your body makes certain physiological changes for that, all right? So you can establish that normal blood flow to your cerebrum especially, so you don't get lightheaded or dizzy, okay, or you don't pass out, all right? But there's been times when those physiological changes don't occur in time. That's when you get orthostatic hypertension. You get such a drop in blood pressure, all right? You get that brief period of lightheadedness or dizziness. God forbid it's fainting, you know, because then you didn't have adequate amount to your brain that initiated the fainting reflex, all right? But when you have those symptoms, it's just because your physiological mechanisms haven't kicked in quite fast enough, all right? And it's happened plenty of times to me from time to time. Has anyone ever had orthostatic hypertension? Stood up too fast? Whoa, getting dizzy. Has anyone ever passed out from it? No. One guy, I'll never forget, I was a sophomore in high school. I didn't really like this kid, all right? And this is another reason why I didn't like him. I remember I was just leaning back in my chair and he pulled onto my head, just was pulling onto my head. So I'm trying to resist him to try to go forward. And he let go, and my head snapped forward so fast that I passed out. And it just, for whatever reason, just that shift in my blood flow, and I banged my head on the desk and fell out of the chair onto the ground. Yeah. So the good news is that I got to miss school for the rest of the day. You know, the bad news is I really wanted to hurt him, and I don't like doing that. Okay, so that's my story for that's it for this chapter. Again, a lot of information in this chapter. So, any questions about what we covered? This stuff today was a little bit easier, I think. You know, not so dense, but really kind of just pour through some of this material. When I say pour through it, just kind of review some of those points. I mean, seriously, those two equations that I gave you. Obviously, you have to know cardiac output. All right, heart rate. Okay, yeah, stroke volume is going to be, great question, all right? The difference, all right, between your end diastolic volume, which is the volume, all right, just the volume of the ventricles of blood, excuse me, it's the volume of blood in the ventricles just before contraction, just before systole, okay? So all the valves are closed, no blood is moving, okay? The atria have just contracted, and that's all the blood is sitting there, okay? Then what will happen then, the heart contracts, it squirts out blood, all right? And then the remaining blood volume in the ventricle at the end of systole is called end systolic volume. That's the blood that didn't get pumped out during the contraction. So the difference, if you subtract end systolic volume from end diastolic volume, that will give you stroke volume, which is the amount of blood that got ejected out of the ventricle during the contraction. On average, it's about 60 to 70 milliliters, okay? Normal, okay? And end diastolic volume is usually about 130 to 140 milliliters, okay? So it ranges.
Because we're going to need that when we're doing the stuff, because you're going to need to know for the cardiac output what heart rate times stroke volume is. You can
Right.
find out what stroke volume is.
Exactly. So you should know this. You should know this equation too. Okay? You should know how to get stroke volume.
Oh, yeah, and I'm going to tell you, about probably about a year ago, my husband got to 50 in the middle of the night, and then like literally he stopped being passed out. So we took him to the doctor or whatever, and they told him that because the reason he passed out is because when men pee, they like stress their body, like they push so much force out of their body that it drops his blood pressure and made him pee.
Well, part of that was from, it's called the vasovagal reflex there. And it's affected partly because of that. Yeah, if you want to, has anyone here ever seen this show Scrubs? No. All right. Anyways, there's a sitcom, and there's one character, every time he went to go to the bathroom to poop, he'd pass out on the toilets. And it's because of that increase in pressure, that increase of intra-abdominal and intrathoracic pressure. It's called the Valsalva maneuver. You increase that pressure to help with the bowel movement. Well, in this case, it put too much stress onto the vagus nerve and the glossopharyngeal, and those nerves help with baroreception and chemoreceptors. So it screwed up their, in this character's case, it screwed up his blood pressure and he passed out. So yeah, oh yeah.
It was funny, like, yeah,
How does he explain